So I hope everybody's had a lot of good takeaways today from the healthcare summit. This session, I think, kind of culminates with everything that we've discussed today and talks about the future of healthcare in India, building a future-ready ecosystem. So, on that note, are we ready? I mean, I just want to start off with just a very, very simple thing. We've built the healthcare ecosystem here. We have digital health and now, telemedicine is happening. Uh, we have a lot of technology play happening in the healthcare system right now. But are we ready? If I was to just take a quick take, maybe I'll start with Roli Singh, ma'am. If you could just, are we there yet for a future? Yeah. Okay, fine. So I can look on both sides. Thank you.
Good afternoon, and thank you for having me for this very important discussion on sustainability and the future of healthcare in India. Uh, from being from the government side, my perspective is, I think, entirely driven, and I'm sorry if it's a little heavier on that side, is driven by the public health, ecosystem. And I feel the solutions lie in the government taking a lead role in providing health care for its people. And the role of the government cannot be in any way diluted or given any kind of a, I would say, I mean, it can't be anything but government leading this space. We are very fortunate to have a very vibrant and a robust private sector involvement, but the role of government cannot and will not, should not be diluted, because we have huge challenges as a country of such a large population of dealing with the challenges of dealing with issues of not only which are which are non-issues in other countries, developed countries, which are in the nature of communicable diseases. A large number of population still suffers from things like tuberculosis, Kala Azar, lymphatic filariae, though we are on the verge of elimination of those diseases, but there is a huge challenge of coming out of that state where we have eliminated polio and we've eliminated trachoma. We're on the trajectory to eliminate other diseases, but there are still huge challenges and other vector-borne diseases that we face from time to time. Then there are diseases which are because of poor sanitation, which lead to diarrheal deaths or which lead to other kind of under 5 mortality among children, the IMR that we keep hearing about. We have made huge improvements. We have covered a lot of ground. We have almost, many of our states are almost looking at international standards when it comes to, when we talk about improving maternal mortality ratio and the infant mortality rate, and under 5 mortality. But still there is a long way to go. And so the role of government will continue to be critical. And I'm sorry, your question was?
No, so are we ready with a future
No, so readiness. So readiness, it's an incremental, it's work in progress. It can, nobody, I think no country can say that we are ready and we have done it all. Everywhere the benchmarks keep shifting, right? So even the developed countries don't say that we have done it all and there is nothing more to do in health. Nobody can say that, because it's an aspirational thing, it's an evolving thing, and we are also looking at a population which is still not aware of how to go about taking care of of health issues. And it is a two-way thing. It is not only the onus is not entirely on the population or the community. It is also the job of the government to increase that awareness level, so that health-seeking behavior that we talk about, that gets encouraged. And we have the ready infrastructure or the ready systems in place in order to deal with that, that scenario where people are actively looking at their health from a very, what should I say, proactive perspective, rather than it being a top-down, a top-driven approach. And And readiness would require not only government spending, it will also require co-opting the private space, which we already have done very successfully, on which Kiran would be able to dilate better. But yes, it has to be a combination of things, with government playing its very strong role in ensuring there is a continuous flow of funds and continuous building of capacities at all levels.
Right.
Thank you.
In fact, I would like to take this question to Kiran as well. The urban-rural divide in India. In urban centers now, there's much more access to technology, and there's a lot of focus now on personalized healthcare, and people are also aware. But how do you transcend this to the rural area where it is still very dependent on that one doctor, one dispensary setup?
Thank you. And thank you for inviting me to this event, and especially on this topic of transforming healthcare in India. So I think there is no initiative that anybody tries to do where this question of rural and urban has come in. Anything you want to do, people will say what will happen in urban, what will happen in rural, whether they will pick it up or not. But I think, it has to start somewhere. And for example, let's take an example for something like MRI machines. Where do you find your MRI machines? You find them in the cities. And now slowly the trickle down is happening when we're like making building machines in India that are more affordable. Where now we are talking about, can each district hospital also have an MRI machine? So the idea is technology adoption will start obviously in the urban areas for the simple reason that it is sustainable there, it is possible there, you find the resources to use. Now, as far as the rural areas are concerned, it will take a little bit of time to develop the models to take it up there. Now, to talk about that example of the rural healthcare small hospital that you're talking about, a PHC, technology is slowly already going there. I mean, the biggest example perhaps I'll say is eSanjeevani. eSanjeevani is one platform that is being run by the Government of India across the country, where around 400,000 consultations happen every day. And the person who is initiating the consultation or the conversation is the one sitting in the primary health center or the Ayushman Arogya Mandir, the CHO, the community health officer who does it. Now, there, I mean, like in rural areas, this is how tech will come in the sense like it will come more in assisted mode, where you will provide, like for example, when we all remember the telephone booths, the yellow telephone booths we used to have when all of us didn't have phones, were PCOs. It's like that. So until technology becomes so ubiquitous and so easy to use for that anybody who with a very little tech literacy, I'd say, until then, the movement towards or utilization in the rural areas would be more assisted. So that is how I think it will go, and that is how it will help. And more and more technology comes in, more and more the people will be, the service providers in the ground level will be able to do what you call the services that they're able to do in a much better manner. Again, giving example of that community health officer, see, every time a patient who comes to him or her, what do you ask him? Yeah, what is your name? What is your address? Or whatever, basic things, allergies. See, there are certain things in our lifetime that won't change. Family history, allergy, and whatever, let's say your whatever previous medication that you were having, right? So if the information is available through use of tech, through the use of personal health records, through the use of the longitudinal health history, I think the ground level officer in the rural areas also will be able to leverage this technology and provide the services better. And in the process, just like WhatsApp, Instagram, TikTok is everywhere, you used everywhere, even in rural areas. Similarly, personal health record applications or tech-enabled systems will be used. And to that earlier question of whether we are ready or not, I think we are more ready than what we were.
Right, right. No, it's interesting you mentioned social media tools like WhatsApp, Instagram, Because I mean, there can be a lot of information and misinformation also transmitted over this, right? Especially when it comes to panic-like situations in health. We've seen it during COVID. How do you kind of manage something like that, especially in the...
That is again a very, very important and valid question. See, the thing is, the problem of misinformation or misguiding will be like a cat and mouse game between the regulator or those who want to ensure that such information doesn't go versus those who would like to do it. Because at the end of the day, there is also a certain level of choice and discretion that you'll have to leave to the citizen also. If we want to completely tailor and doctor everything and make sure that only this information flows, perhaps you are missing out on certain things that technology will unravel. And at the same time, if you leave it, then perhaps it won't help. But I think what the least we can do is, see, with technology, the problem is any technological intervention, we always overestimate the short-term effect because we think that एक technology ले आएंगे तो it will change things so much, and we completely underestimate the long-term effect.
Right.
So I think if we are able to understand this and then slowly make sure that whatever technology is coming in, it is carefully regulated. I mean, I would rather use the word, instead of using regulated, I'd say curated, to make sure that these kind of anomalies does not happen.
Right. Okay. Yeah.
This is a very interesting discussion. I'm a cardiologist, so some of my examples will come from the heart. See, talking of how the system is building up for rural areas and also for the urban areas simultaneously. The ICMR, for example, a couple of years ago, they asked the specialists from different areas, and I was a part of the cardiology group in that. So they say you identify the common diseases related to your specialty, and then you frame guidelines based on what a person has to do if he is at a PHC level or at a district hospital level or at a medical college level. So those kind of guidelines are being provided by the government. India is also using its own strengths. We all know that we have the highest number of telephones, mobile phones in the world. So in the South, for example, there is already a system in place wherein a person, when he gets a heart attack, for example. So there are 3 standard modes of therapy. You either do an angioplasty, put in a stent, or you give a clot-busting medicine, or you use combination of both. So what these people have evolved is what is called a hub and spoke model. So you have a hub which is capable of doing an angioplasty, which is gold standard. But you have spokes which are essentially rural areas. And these people, they send their ECGs. The doctor in the hub tells them, look, you are that much distance away, so you better give a clot-busting medicine and bring the patient to us. So we are kind of able to evolve our strategies in our own way. That is something that I thought is
interesting. Yes, interesting use of technology here, because the mobile phone can be the method of consultation also, which we've seen with a lot of apps.
It absolutely is. In fact, telemedicine is very much a part. The government took that initiative way back in 2020, and we developed a model which is called e-Sanjeevani. So you can have consultations, and there are guidelines in place from the National Medical Council and also the government, which tell you which things you can have teleconsultation on and which things not. For example, the mental healthcare problems, the mental diseases, they are very, very amenable on, internet, on the in a digital, in a telemedicine form.
Right.
You can really have very good, but if you have other problems, there are many diseases, emergencies, for example, you would not like to take a chance on telemedicine.
Right, right. So with technology changing and with access to all of this digital health and all that we have right now, how much of reskilling is required in the existing healthcare workforce? Because you have new technologies emerging every day, but I think the level of practitioners that we have probably they've done their medicine 15, 20 years ago. And while there are courses that doctors go through and retraining programs from time to time, is this prevalent across the ecosystem? I'd like to take this question to you, sir.
Yeah, thank you very much. I think to answer this and also a bit of uh, compile what every panelist has been saying, I think all of us, I think, on the panel are about the same age group. So when we were growing up in the 1980s, if you had a heart attack in Delhi and you wanted an angioplasty, you actually had nowhere to go but to either to Chennai or to the east coast of the United States. That was how Delhi was a net exporter of medical tourism at that time. That is exactly what the current small towns are facing, right? So if you have a heart attack in a town like Kethal, you may have 100 crore rupees in your pocket, but you have no choice but to go to either Chandigarh or Patiala or come to Delhi because there is no cath lab available there, no cardiologist available there. So how do we make sure that we can upskill all our healthcare workforce enough so that we can distribute all of them in the 810 districts of India right now. Out of the 810 districts, more than 500 do not have access to any sort of emergency super specialty care. We can speak a lot about technology, and as Sir said, in some ways, technology and telemedicine is very important. Like in COVID, we had a not-for-profit voluntary organization that we set up as started as a small WhatsApp group when telemedicine was actually illegal in India. It was called Founders versus COVID, and then we changed the names as it blew up very, very, randomly suddenly it blew up and it finally was named Project Step 1, where we had 12,000 doctors volunteering on the platform and calling out to people and working on behalf of all state governments. We worked with 21 state governments. If you had COVID, you had this call coming in that we are, talking from Delhi government behalf and you have to stay at home and you have to follow these guidelines. And then plasma banks on how to get plasma, then vaccination, how to get. So all of this was being done that. So on that sector, I think it's very good. We run also in Kashmir, we run a telemedicine helpline, which is based out of two of our hospitals in Srinagar. But it cannot really supplement the hospitals because that telemedicine helpline is mostly on mental health. And Kashmir as a community is in dire need of mental health helplines. But then it is also in dire need of ICUs, it is also in dire need of cancer treatment, it is also for cardiology. So 500 districts not having access to cardiology right now, technology will not really supplement the fact that we are producing only about 220 cardiologists per annum in the country. We are producing only about 70 endocrinologists per annum for a population of 1.5 billion people. So these things will have to go hand in hand. And we have to make sure that technology aids these doctors and paramedical workers a lot. So I feel that technology will not be able to supplant the doctors completely, but supplement the doctors definitely. So doctors who use technology can take over the entire practice, but technology cannot completely replace the doctors.
An interesting point you make. You want to add to that? How do we increase the use of technology and get healthcare down to the rural levels? You also made the mention of public-private partnerships. How do you think this could help in this area? Yes.
But I think before that, I would like Dr. Bansal to throw
Yeah,
some light
actually,
on this cardiology.
He mentioned.
Are those correct numbers?
Ma'am,
Yes.
sorry to be correcting, but I've been a part of the medical education also for the ministry. So I'm aware that there are almost 850 cardiology seats in the country. In fact, in one of the meetings, my Assistant Director General Medical Education said, sir, 180 cardiology seats are vacant. I said, this is 3 times the number of total seats in the country when I did my cardiology. So there was a time when they were really less, but now there are, cardiologists. We have close to about 5,000 cath labs in the country. So the numbers are growing in the center also, but also in the peripheral towns. As regards this, the skills, the knowledge is expanding far too fast. In fact, when I train my fellows, I tell them that, the entire angioplasty that I studied is now a very small part of total angioplasty is equal to what I studied in its entirety. So that much is the expansion in terms of knowledge. And it is a constant, slow and constant progress. We really get a very good support from the private sector also for knowledge supplementation. We have a lot of meetings, we have a lot of conferences where knowledge dissipates, and a lot of younger crowd. We see, like, particularly in my area, you would see thousands of young people coming to attend those meetings because they want to upgrade their skills.
Right. Yeah.
So I think basically the issue is of matching demand with supply. And we are aware that there is a gap in the rural areas because if we expect the private people to go and set up shop in an area where people don't have paying capacity or that they're not aware of the critical mass for a thing like, say, a cath lab, I'm not sure whether that's going to happen. Again, I come back to the point that it has to be, government has to take the lead, supplementation has to be done by private partnerships. And somebody mentioned the equity model from one of the speakers here. I think it is a brilliant idea, and I think it is the future, where we can partner with the private in a way that, there is a equal stake of both parties, and we know what the end goal is. And there is, of course, a reasonable revenue model built in so that the private people don't feel, obviously they're not going to pay from their pockets. But government's basic responsibility is there. So government brings in the necessary viability gap funding which is required, brings in, more resources which help sustain that private work. But that is, again, that's an idea. And I'm sure we have already, like I said, co-opted private in a very big way in our hospitalization care through PMJ. The CGHS, which is an assured health scheme for the pensioners and the central government employees, has about 2,300 private empaneled hospitals on its panel. And I think with the rate revision, I'm hoping for at least doubling that number, if not more, across the cities. PMJ on its own has, I think, 30,000 private hospitals. But that is, again, on the curative side. Coming back to how technology can be a game changer, you mentioned e-Sanjeevani. I feel the technology is a good idea and technology is required, but it cannot be delinked from human capital. No technology will work if the human resource behind it is not aware or is not, up to speed. So we need to see that where is it that the gap is because of lack of awareness or lack of thinking through the solution of that problem. Like we have a Telemanas, which is a brilliant scheme, a hub and spoke model for taking care of mental health. And when I was speaking to some development partners, the idea just came to me. We were just ideating that what about adolescent health? Are the counselors that are hired through this Telemanas system in the state governments, are they going to be equipped to handle issues of adolescent health? That requires training. We have a shortage of counselors, but whatever counselors we have in the ecosystem, we need to augment capacities of counselors to handle different kind of issues. So we decided to do a proof of concept in a small area where we bring in people who help us provide that capacity gap, build that capacity gap, how to train those counselors on handling adolescent issues, because I think a tele-mental health line is something which adolescents will use very easily and freely, because they are, they are more aware, and they probably will be better users of that avenue than, say, an older person like me or anybody else. Anyhow, so that kind of gap filling needs to be done, and that's where we need to bring in our private, our not-for-profit or for-profit or private players to build in those capacities. A similar example is of the dialysis facility that we have in our central hospitals. It was just by chance that one organization came and we had a discussion. They said, we'll help you build capacities of your technicians for doing hemodialysis and all those other related activities that need to be done to handle CKD. So from a 2-bedded facility in LHMC, we are up to 22 beds, only by collaboration and, bringing together capacities and resources of government with the capacities of the private. And they are building in capacities, they have brought in their own technicians, which will be there for a short while for hand-holding. The machinery has been brought in on CapEx kind of a model, which will become the department's, which will be owned by the hospital in the years to come. And similar augmentation has been done in Safdarjung and even in RML. So there is a constant need to engage and network. That without that we cannot, nobody can do it all on their own, because there's a lot to be done. And I think to your observation that how will our people use technology, I have a view on that, that it is not rocket science. I think Indians have proven to the world that we are the most tech savvy people in the world. The way you see UPI has taken over, the way we use, the whole money transaction scenario has changed drastically. Even the people from the US, when they come, they're shocked to see how agile we are with this this technology shift. We don't use paper money the way we used to earlier. Even our thela wala knows how to operate that. And we have our ASHA workers operating smartphones to fill in data on, or our Anganwadi workers filling in data on the, the critical health parameters or family data that they have to fill up on the smartphones, instead of the 16 or 17 or 20 registers that were being filled in earlier. So that transition happens quickly, provided we make it, focused. I mean, we are outcome focused on what kind of technology we are bringing in and for what purpose.
The other thing is, for a future healthcare system, prevention will probably be better than cure. Right now in India, we're still reactive. We are not proactive. And we have this, and it was discussed in the morning also, we have this huge problem of non-communicable diseases. In India, nearly 65%, I think, of the population is susceptible to NCDs. So in such a situation, what do you think we should do at this moment to try and reduce that number, or at least make it proactive instead of reactive treatment that we have right now?
Thank you. Thank you. This is the problem of what we call closing the loop. We have primary health programs run by, let's say, one particular division in the ministry, the National Health Mission, that does reproductive and child health, that does TB, it does non-communicable diseases, it does a lot of other programs. And day in and day out, these programs are churning out potential cases, or what you call screening the cases out and saying, okay, they need the treatment. The gap that you're talking about is absolutely valid, because on the other hand, we have programs like the PMJY, which has technically underwritten 40% of the country's population and said that, okay, you fall sick, government will pay. Now, how do you marry these two entities? I mean, on one hand, you're finding that somebody has, let's say, advanced stage cancer, or somebody who is diabetic, or who has other complications on account of diabetes. Now, if they need a hospitalization or they need an intervention, you need to bridge this gap. I think this is exactly where technology can come in, and this is exactly what is the promise of the Ayushman Bharat digital mission, where we say that every citizen has an ID, every citizen has a longitudinal record, and by virtue of the data that is getting created, the healthcare provider who is working at the field level is able to identify a person and Also, based on the guidelines, he or she should be able to refer the patient. So we build a referral system, for example, that is listening. Like let's assume like there is one referral system that is listening to what referrals are coming from the ground. And let's say one patient has been identified that he needs surgery, and this referral has been registered by this entity, that entity which is listening. In computer science parlance, it is called a daemon. It's like running on the network and it is listening to what's happening. Now, this patient is expected to go to a nearby hospital. Let's say that patient is a PMJAY patient, because I'm talking about the poorest 40% of the country. So now that patient is expected to go to nearest PMJAY empaneled hospital, public or private. Now the system is waiting for this referral to convert into an admission. Let's say you give a time of 3 days that it should get converted. It doesn't. The referral system is backed by a call center. The call center calls up the patient, asks what happened. आप आए क्यों नहीं? You were supposed to be there. आपको hospital पता नहीं चला? या what happened? Did they deny you treatment or anything like that? Then you get the feedback saying, no, I will go after 2 days. You're fine. After 2 days, you're following up and making sure that it has converted. Let's say you are not able to reach him. Now, by virtue of this overall connected system that we have been able to build through the digital mission, you know who referred that person. The health professional registry helps you do that. You talk to him because he's out there, she's out there in the field, closest to that person, and say, you referred somebody, what happened, why hasn't he turned up? So it is the responsibility of the frontline worker to respond saying, okay, there was this problem, no, he's going back now. Now, once that referral converts into an admission is done, treatment is done. Once the treatment is done and the discharge is done, it is again relayed, the referral system again relays back to the referring entity saying, your patient has been discharged, now he's coming back to the community level. Along with that, the discharge summary, the health record, the reports and other recommendations given by the treating doctor are also relayed back to the community level medical officer, who can then take care of the person. And then today, our essential drug list at the PHC level has increased. We have increased the number of medicine we give there. The number of tests we do at the PHC, CHC, and even the sub-health center level, which are called the Ayushman Arogya Mandir, has increased. So now this person who was identified for for certain treatment was given the treatment. Now he is back in the community and he is receiving the community. Believe me, this is what you will see very soon. This is what the ministry is currently working on. How do we connect these dots? How do we make use of the technology architecture that we have built in the name of ABA, HPR, HFR, the health exchange, and all that? And then the results, as it is, why this is important? There is a Lancet study which says that the probability that a cancer patient receives treatment within 30 days of identification of cancer is 90% compared to 33% to a non-PMJY patient. So the chances are more. So basically, if you are a PMJY patient, if it is identified, then the chances are 90% more than when you are not a PMJY patient. So on one hand, the government has given that assurance to the 40% of the country saying, don't worry, we are there for you. On the other hand, these linkages between those 30,000 hospitals and the 175,000 Ayushman Arogya Mandir at the field level are going to ensure that this loop gets closed, and this gap of identifying patients at an early stage, and ultimately underwriting those 40% means I am an insurer. I want to keep them happy. I better spend 15,000 on medicines or early cure now rather than spending 1.5 lakh later on. So this is the paradigm shift that you will all see in how healthcare is going to be delivered.
Supplement, sorry. So just this idea of how you identify at the right time. So the screening which is happening at health and wellness centers is a very, very critical aspect of it, because that's what we call the Ayushman Arogya Mandir. They're right at the grassroots level, the sub-centers. And I think that's where Government of India has shown its intent of investing in universal healthcare, because that is where it should be captured, and that's where the community issue should be captured, health issues. So I can tell you that there are certain states which are doing it in such a robust manner. For example, Andhra Pradesh has geotagged its health and wellness center, the Ayushman Arogya Mandirs, to the population it caters to. So they know very clearly that this the Ayushman Arogya Mandir will be catering to these 15,000 people or 20,000 people. And they have ensured screening on the 14, all the NCT screenings that we are talking about of all the population above 30. And now they've gone 3 times because it started then 3 years back when I was in NHM. I'm sure they've done 3 cycles of it. So there are states with capacities building like that. But then again, I'm coming back to capacity. It differs from state to state. It differs on because of the governance patterns or these systems that there are in place. I'm sure Kerala is also doing something like this, and we are all moving towards that direction where we need to know what is our client base in government. Unless we are sure of that, we will never be able to have this data, and this whole loop will not be closed because the referrals will emanate from there. And coming back to AI, I know of I'm just giving an example, it's anecdotal, of a friend's child who has just passed out of IIT few years ago. He set up a company in the USA, sitting somewhere else in the world, which will precisely track the ECG data of a certain population set and try to do predictive modeling on who are likely to get heart attacks. So that will be something which will lead to this kind of startup in this area is what is required. This is where AI should be, this is the kind of AI which will help us. And that's where our sharing of data will become important with this kind of a.
You wanted to quickly add to that?
Prevention of disease. 3 facts. Number 1, this is from an American insurance company. Prevention of disease costs 1/6 the amount that is needed to treat a disease. So for a country like us, prevention is the way to go about it. The 2 most important things which are needed for prevention are, one is our media. I was asked in one of the meetings, what is the best way to have prevention of heart attacks? I said, rope in Amitabh Bachchan. Because when he speaks, everybody in the country listens to him. If he speaks, go for a jog, take a healthy diet, those simple messages, the ministry has a group. I'm a part of what is called a IEC group. We put the messages on social media, but we have limited access. So media has an extremely important role in prevention. That's one. Secondly, time and again, we have realized that Indians get their disease very early. You guys publish so many details. A guy who was 34 had a massive heart attack and died. Person was in gym, he died. So we get hit very early. So the age to strike is actually at the school age. The CSR activities, the corporate social responsibility activities, they should focus on adopting schools wherein they promote health activities. The children are most receptive. They can tell their parents that we would not like to go outside and eat. All the diseased food which is responsible for non-communicable diseases, the burgers and the pizzas and whatnot the younger generation eats. The whole concept of eating at home is gone. So those are simple preventive strategies that we need to adopt, strike very early in life, and have some people talk to us repeatedly.
Okay. Very quickly,
Adding on to Sir's point on prevention versus the treatment cost of the disease, I think we fail to estimate the true cost of the disease by a wide margin when it actually happens, right? So, for example, we have about, say, 100 million diabetics in India, and we know 1/3 of them will end up into kidney failure. Kidney failure's largest cause is diabetes by far. So if a patient comes with kidney failure due to diabetes and a gangrenous foot, we are amputating almost 1 foot every 5-7 minutes due to diabetes gangrene. And we say that we can pat ourselves on our back saying we are a very affordable hospital chain, we cater to PMJY patients, we've been champions of the scheme, and we'll amputate your leg for free and do your dialysis for free. And if you had gone to a big city hospital, it may have cost you a lakh or 2 lakh rupees. But is that lakh rupees really the true cost of the disease? Because now he doesn't have a leg, because now he's on dialysis twice a week. He can't really go back to the factory he was working or the fields he was working, right? So the future earnings that he loses runs into many, many, many millions of rupees. But the scariest cost is the intangible cost of disease, which we really don't measure. Because now you don't have a leg and don't have a job, you will pull your children out of school and start sending them to work. So one of my colleagues who drives me around to all our hospitals, we have 28 hospitals across North India, so I'm driving to the hospitals all the time. One of my colleagues who drives me says that, sir, till 6th standard, I used to come first in 2 subjects always. All my races, I was first, and in mathematics, I was first. I used to score 100 on 100. Then suddenly my father died, I don't know why. So my mother said, now you have to start working because somebody has to earn. So I started doing odd jobs and now I'm driving a car. If his father had survived and managed his heart disease or diabetes or whatever, he may have been doing something very different. My father used to make kites for a living early in his life. Luckily, he survived and I could do medical college and study for 12, 15 years. If he had died early, I may have been making kites right now and not sitting here, right? So the true cost of the disease is very, very different from what we estimated to be.
It's an interesting point, and we're almost out of time. So just a quick last point that I wanted to ask you about. You had mentioned the Ayushman Bharat digital mission. Now, there's so much of data that the Ayushman Bharat digital mission is collecting. And this data, shouldn't it become interoperable so that it is accessible across the healthcare ecosystem? And if that happens, there are risks as well. In terms of data leakage, and it can be misused, or maybe you have a lot of insurers also who use this kind of data for the wrong reasons as well. So how do we prevent that happening?
I'm very happy you asked that question because this is the common misconception of ABDM, the digital mission that most people have. Digital mission has no data. We at Government of India who are running the Ayushman Bharat digital mission, we have zero data. Let that be very, very clear. Data is sitting wherever it is created, exactly what it was earlier. You went to AIIMS today, AIIMS created a prescription for you, AIIMS created a diagnostic report for you, it is with AIIMS. You went to Medanta, Medanta created a record for you, it is staying there. It is not at all coming to us. Let us be very clear about that. Now, the interoperability part. See, the whole objective of ABDM is to ensure that this information easily flows from one entity to the other. Now, obviously, AIIMS has no way to access Medanta system to directly pull the data, right? So that is where the health information exchange comes into picture. The health information exchange is the medium through which these two talk. But even then, these two talking is only possible with the consent of whose data it is. So yesterday I went to AIIMS, let's say, and AIIMS created one data point for me. AIIMS is storing it, or I am storing it on my phone, my responsibility. And tomorrow I've gone to another hospital. That hospital is saying, look, obviously, maybe I want to share that. I want to share that data with them. Like, for example, I said, the entity and longitudinal history is so useful, and in fact, a summary of that longitudinal history is so useful to the next physician that he or she will actually be able to assess me much faster. And we all talk about this, that amount of time that we can save on consultations can happen. So that new hospital will ask me my permission only, then this data is going to come from AIIMS to them. Even there, the digital mission cannot see what data is flowing. We are totally data blind. So rest assured that there is no way, and it is as exploitable as it was earlier. Nothing has changed. There is no honeypot that if somebody is going to crack and they are going to get access to this data. Interoperability, yes, we are ensuring this. When we are saying that, let AIIMS, as for example, if AIIMS is running some system, and internally within AIIMS, they will be free to use whatever standard they are using. Another private hospital, internally, they may use whatever standards they are using. The moment they are exchanging records, They have to use a common standard. That is why otherwise you won't be able to understand. Simple example I'll give you. Let's say I'm sharing my email with you, and I'm using Gmail and you're using Yahoo Mail. Now I am able to send an email from my Yahoo Mail account, Gmail account to your Yahoo Mail account is only because both Yahoo Mail and Gmail are following one common protocol called SMTP, Simple Mail Transfer Protocol, where you have this header from to subject body. Now, when I send it with those tags, it goes to Yahoo. Yahoo reads those tags, and then that is how it is able to show it all on your browser. Let's say there is one field called date of birth also in that. Now, if Google stores date of birth as DDMMYY, and Yahoo stores date of birth as YYYYMMDD, then there will be havoc. There will be no understanding. This is exactly why common standards are important when data is getting exchanged from A to B. So technically what ABDM is doing is, we are saying, look, use a common ID for the patient so that when he comes from one facility to another facility, you know that person. Use a common data standard for exchange. And finally, there is something called a consent manager which makes sure that the citizen to whom the data belongs is always informed, and without the consent manager or the data principal's permission, no data will move from A to B. In fact, I would say ABDM was DPDP compliant even before DPDP came in, the Digital Personal Data Protection Act. So that is how the whole thing has been built. Yes, technology can have flaws, there can be some things, but then this is a continuous process and we will only be strengthening it further. And the ABDM framework is in fact one of the information infrastructures declared as critical. We are also observed by what is called the National Critical Information Architecture Protection Center, Infrastructure Protection Center. So these are all monitored. So this is a very, what you call, robust system that has been built on the which makes sure that the citizens, nothing moves without the citizens' consent, and there is no single data repository that anybody can come and hit and take the data away. And last, insurance. Okay, if all of us were to go and buy insurance today, how will the insurance company rate our premium, decide our premium? Average. Some of us may be sick, some of us may not be sick, some of us may not be requiring the kind of, medical attention at least for some time. Are you willing to pay the same amount of premium as someone who would be using the system much more? No, right? So having access to this data will only help actually arrive at the right premium, actually arrive at the right pricing. And again, there are ways of mitigating the risks of what will happen if data is going and I'd say, if there is a, let's say, the whole idea of misuse, unless you want to hide the data for some reasons, I think more and more data will only help us take better decisions. More and more data will only help us price things better. More and more data will only help us decide things in a much more efficient manner. So that's the whole thing about the digital vision.
Okay, this is a discussion just got very interesting, but unfortunately we are out of time. We'd love to have more of this later, but on that note, I'd just like to thank everybody for joining me on this panel. Thank you so much.